much. It's a great pleasure for me to be here with you to share a small window on the research in nursing science. I will speak in English. I prepared my slides in English, so I would like to make my presentation in English. I would like to thank Réseau Québécois for suicide, mood problems, and associate problems, who allowed us to conduct this research, and our partners.
Just a couple of questions, and I think we've started to answer these this morning and over the last 2 days. What does quality of life represent? And in this case, I'm going to be talking about suicide, vulnerable children, and youth at risk for suicide. What is in the best interest of children in these situations, according to the child and according to the parents? What is helpful from their perspective? We have a lot on the professionals and what we think and we believe, so we're trying to go into, again, working partnerships with children and families. I talk a lot. I don't want to go over time, so I am going to start with just a little bit of the conclusions and take-home messages, that community social pediatrics is a continuum. It can and must be practiced across all healthcare settings and social settings where children and families receive care and service. So from schools and playgrounds and community centers, which we talked a lot about, but also into tertiary care hospital settings. There's no reason why we can't bring this approach into our hospital settings where vulnerable children are going through difficult times. The other take-home message is that children and parents have very clear ideas about what's helpful to them, and that helpful care for children and parents is complementary and reciprocal. So when we help a child, it's helpful to the parents. This is what we've learned. And from the child's perspective, helping their parents helps them. So just a little bit of background about youth suicide. It's a very complex phenomenon. About 1/4 of youth in Quebec report suicidal thoughts or attempts. It's the #1 or #2 cause of death of youth in Quebec, and it's a significant public health concern. I love the work of Michael Meany, because in nursing we're looking for what is our theoretical scientific background. And this model is a very simplistic model, but what we're interested in nursing are the protective factors and the factors that can promote health. And when we see those rat mothers licking their pups, that's nurturing, that's caring, that's a lot of what's at the heart of nursing practice. And if we have some neurobiological data to show that these interactions really do make a difference because they're invisible. And so that science is really helping us to value, and I think what we all have a role in caring that's shared by all of us, and some of the relational skills that we've been talking about belongs to all of us. So these are very powerful scientific data that support what we do. So very simplistic model here, but the intervention, a caring, nurturing, responsive interactions with vulnerable children can lead to outcomes where we are promoting child health and well-being and quality of life. I'm going to talk to you a little bit about the nurse's role in youth suicide in the traditional sense of the word in the tertiary care settings. Nursing staff spend more time interacting with hospitalized children and parents than any other professional group. So the parents may come in to visit, and I don't consider them visitors, they're care providers, so they may come in to care for their child. And they come in at all times of day. We've gotten a lot more open about visiting hours, which is great. We should have it open everywhere. Parents and nurses should be working as partners in care a lot more. Nurses spend a lot of time. During suicide risk, it's an intensive care situation, so children will be put on what they call one-to-one observation. So they will have one nurse or frontline staff member assigned to them 24/7. You can go from constant observation to close observation, which might be every 10 minutes check in with that child. So it's very, very intense. What is going on during that time besides surveillance? And they call it surveillance en français, or observation. And there's a lot more going on than observation, because you've got to interact with that child. How are you interacting during that period? We know very little about that. The vast majority of clinical research related to suicide focuses on interventions delivered by professionals other than nurses. Nursing is a very young science, so we're getting there. It's taking us some time. Little is known about the actual and potential impact of nursing care on the health, and that goes beyond illness prevention and keeping these children alive and safe. The health of children and their families. We want to look at the positive, what can we do? Current studies do focus on a lot of prescribed treatments and control measures, evaluating risks, and yes, the nurses go around with the clipboard, how suicidal are you on a scale of 1 to 10, and you say 5, okay, or you say 10, and then there's a certain range, and these protocols are very, very clear. If it's a certain 8 to 10, then the child has to be on constant observation. Etc. Room searches, searching for rooms, removing dangerous objects. That's also one of the tasks that nurses do. How is that carried out? That is a huge, I think, invasion of privacy. We talked a little bit about environment yesterday, and some of the rooms that these children in are very bare, because they're not allowed anything because they may harm themselves. So they're in these very bare rooms. And so we have to look at the implications for the environment as well. The target outcomes in suicide clinically are patient safety, physical protection, preventing self-harm. Those things are important. We can do that. You're watching someone 24/7. They're not going to harm themselves. That's easy. What happens after that when you start removing those control measures? However, there is very limited research that suggests that and we know this, that the attitude and the relational approach has a significant impact on health outcomes. And available data indicate that suicidal patients on close observation report increased or decreased feelings of hope, self-esteem, and other factors resulting from their interactions with nursing staff. So we can protect them, we can keep them safe, we can look at them and observe them, make sure they don't harm themselves. But how do we promote health, hope, for example, and self-esteem in a child who wants to end their life? So 2 research questions. We did 2, I'm going to talk a little bit about data from 2 separate studies. One was done with adolescents, the other one was done with younger children and parents. So what are the perceptions of adolescents at risk for suicide regarding helpful care? And we're looking at what's helpful. There's a lot of unhelpful things going on. We know what those things are. What are the perceptions of younger children with suicidal risk factors in their parents? Why study youth and family perspectives? Again, if we believe that families are the experts and children are the experts, and that they're active participants in their care, then we need to invite them to help us learn what's helpful to them. The research was done at the Douglas University Mental Health Institute. The sample for the study number 1, that was the adolescents, youth 14 to 19 years old, presenting with suicidal risk at any level. And that was we interviewed them either during their hospitalization when they were on that suicide protocol, or within 6 months or a year after that hospitalization. So some of it was retrospective. And in study number 2, we looked at children 11 to 14 years old with suicide-associated risk factors. So we don't want to wait until these children become, wanting to end their lives. We would like to intervene early before that happens, but we know the backgrounds of the children in the the younger children in the pediatric services have these risk factors. So we interviewed them, and we also interviewed parents, all of whom are moms. We need to do a much better job of getting dads involved. And this was qualitative research and convenience sampling, and the interviews were audio recorded and transcribed. So I'm going to get to the findings here. From the first ones was from the results of some of the adolescents. And these interventions that the children are saying are helpful do not cost a lot of money, and they don't need a lot of training to be able to do. Some of the complex, CBT, DBT, some of these other interventions, they require a lot of training. These are things that we have naturally that we can use as interveners. And they're not just specific to nursing, by the way. I think all professionals can use this. So here's what some of the children had to say. Smile. And be friendly. If someone's smiling, you're smiling. It can spread. I don't know of a pill. Remember, these are suicidal adolescents. They're on antidepressants. So children are beginning to make the link between the outcome and the intervention. So this smile has an effect on them. Be intimate. Don't talk in the doorway. Come and sit with me, beside me on my bed. Notice what's important to me. Sorry, I'm having trouble. I'm going to read off my sheet here. Notice what's important to me. If there's something special I want, like chocolate milk, make sure it's there for me. This is important to the child. This is what we should do. A lot of times children are told, well, this is not a hotel, you're in a hospital. Not a very therapeutic response. Talk to me. It really helps when someone is there to enter into a conversation. Ask about my life and about my interests and what we do. Asking everyday questions like, how's your day going? Helps us feel safe. You're looking at an adolescent who is suicidal, so safety and feeling safe is very important. Working in partnerships. So we had actually a lot of categories on the interpersonal, that caring relationship. But we're also looking at collaboration. And what does that look like? If I speak of suicidal thoughts, be present and listen. Don't panic and take away my privileges. We just want to talk when we're feeling bad. Okay? At this point, we're obliged to intervene. We need to include our youth in some of these protocols that we have. Because what happens is children don't tell the truth. They'll say, "Oh, I'm feeling fine. When you do the checklist, I'm just a 1. I don't feel like harming myself." And they say that because they want to get out. So we have to be very careful of how valid those tools are as well. Probably the most important thing is actually understanding, not just on a scientific level, but on an emotional level, how deep the despair is. Again, these are invisible strategies. They're talking about listening without trying to fix the problem. Learn to trust. That is a big one. We talk a lot about interventions to try to get the child to trust us as health professionals. I think we have a much more difficult job trusting children and believing in them, especially when they have mental health issues and particularly when they're suicidal. Believe in me. We're the best judge. No one knows better than me if I'm going to kill myself. Identifying and working with strengths is a huge area as well. Focus on the positive. Make the parents, I'm having trouble reading my own notes. Notice that the parents care. That will help so much, because in therapy, you're saying your problems. It's negative. The positive can make a happier environment. Pointing out the things you're going good at makes you want to change, makes you want to live. It really does. It makes you feel that you're not completely worthless. Suicidal children, hope and wanting to live is a very important outcome. And again, no pills and no scales that I know of can make that outcome happen. Creating a health-promoting environment, we talked a lot about that yesterday as well. Just being able to feel the sun, going outside, it really helped. You get the feeling of liberation. I felt like I wasn't in a prison. We have beautiful grounds at the Douglas Institute. What's ironic is that the more suicidal that child is, the more, plus qu'on les enferme, we keep them more on the unit and even confining them to their rooms. So we have to look at some of these protocols. Very quickly, looking at some of the, these are some of the data from the parents and the younger children. Caring for me as a special person, these are side by side, so you see they're complementary. The nurses understood him and would sit next to and talk to him. He was scared. They took so much time to make him feel it's okay, you're okay, and I appreciate that so much. So again, you're seeing that how that's helpful to the parent. When we ask these questions, we ask what's helpful to you. We didn't ask what's helpful to your child. Things that make me feel better to talk about, things I'm going good in, again, looking at the strengths in the younger children, the same concept is coming out. We went to the market with the nurse. We bought stuff for pizza. We took the bus. I had so much fun. These are important. We have an ethic that when you're in hospital for mental health, you have to suffer in order to get better, and that having fun, the child's really not addressing their problem. The nurse is fun, telling jokes, laughing, use of humor is very important. These data right here show very clearly when we asked the child what's helpful to you, they started talking about their parents and the needs of the parents for support from the nurse. Well, I'm sure my mom was always a bit sad, like about my problems, but I think she knew that the nurse was always there to help her, to help me. My mom really likes the nurse because she really helps. She'll never abandon us. We also have some direct interventions with the parents. She makes me feel like she's almost a friend. It humanizes her, helps me feel comfortable. I've never come across anyone who showed that much of a kind of empathy. I'll end up feeling like my bubble's been bursted. Again, empathy and the importance to the parent that can then help the child. So this is a little model that we have for family-centered nursing, family-centered care. I think this belongs to all of us, not just nurses. And that some of the key strategies are invisible. They're not checklists, they're not taking things away, and you can just chart that you've done them, so we have to do a lot of work in that area. Really future challenges is making the invisible visible. These human interactions that we're talking about are important to label. And then they're also important to measure, and so I was very encouraged this morning with some of the talks looking at measurement tools. My dream is that we have an in-time way of measuring through neurobiological changes how the interaction is actually affecting the child. So thank you very much for your attention.